Hello, everyone, and welcome to today's episode of the Clinical Cocktail. Today's topic is going to be Achilles tendinopathy, specifically how I would go about diagnosing as a certified MDT. We're going to be pairing today's lesson with one of my favorite cocktails, a Manhattan. Let's clear one thing up right off the top. It is not tendonitis. That's old terminology. We lean more towards saying Achilles tendinopathy now, and that's because the itis suffix indicates that it's an inflammatory condition. While this may sometimes be the case, it doesn't accurately describe what's going on within the tendon or within the condition itself, and could potentially lead us down the wrong treatment path. All right, now that we have that out of the way, we can begin. So, the first thing we are going to do is add some ice to our shaker. So the first ingredient in our Manhattan is going to be a healthy pour of a Canadian whiskey or other rye. I prefer Canadian whiskey. We're going to do 3 parts. Achilles pain is really common, especially in athletes. About 52% of runners will experience some Achilles pain at some point in their career. For other athletes, it's about 24% of people will experience pain, and for the general population, about 6%. Now, we can break Achilles tendinopathy down into 2 categories. 1, mid-portion Achilles tendinopathy, or 2, insertional Achilles tendinopathy. The difference being the location on the tendon where you are feeling pain. Now, does this really matter? Not particularly. There's not a huge difference in the way we would go about treating it. There is some evidence that mid-portion tendinopathy will respond well to shockwave therapy. With regards to insertional tendinopathy, there's often a palpable bump where the Achilles inserts into the calcaneus. However, treatment protocols are relatively the same for both. The next ingredient in our Manhattan is going to be sweet vermouth. We're going to go with the classic Martini and Rossi here, and we're going for 1 part of sweet vermouth. How do we diagnose Achilles pain? For me, the subjective history is the most important. While I am interested in the Achilles pain, I'm also trying to figure out if there are other factors that may be contributing to the condition. Do they have leg pain? Do they have pain in their lower back? Do they have a history of trauma? And how does that pain behave? All of this will help me build a clinical picture of what is going on with my patient's Achilles tendon. Some consider it optional, but not me. We are going to add a couple dashes of bitters. For example, if I have a patient reporting a history of lower back pain, knee pain on the same side that they have Achilles pain, pins and needles sensation, and pain at rest, I'm starting to think that their pain may be sourced from their lumbar spine. However, if they describe no history of lower back pain, pain worse with running, specifically at the beginning and ending of the run, that gets better with rest, and is tender to touch on the Achilles, I'm starting to think that maybe we have a tendon issue itself. I prefer my cocktail stirred, not shaken for a Manhattan. And I use a trusty chopstick. Nice vigorous stir. From there, using the McKinsey method, I will perform objective testing to determine one of four things. 1. Is the Achilles pain a referred pain from the lumbar spine? In the absence of trauma or inflammatory conditions, up to 72% of all leg pain is referred from the lumbar spine, and 29% roughly of all ankle pain. So it's a good chance it could be coming from the lumbar spine. Number 2, is the Achilles pain related to the ankle joint? Repeated loading of the ankle joint into plantar flexion or dorsiflexion may reveal that the pain is actually coming from the articular surfaces of the joint and not the tendon itself. This can be the case in about 25% of patients. Number 3, is the Achilles pain actually the Achilles tendon? And number 4, is the Achilles pain something else altogether, like hormonal imbalance, metabolic causes, drug interactions, or systemic inflammation such as lupus? To effectively assess above, I would test strength, range of motion, orthopedic testing, and some functional movement testing to determine what the patient's deficits are. From there, I would see how these baseline tests respond to repeated movements of the lumbar spine or repeated movements of the ankle to determine if we have a spinal source or articular source. If these don't make any change, then I'm going to assume it is the tendon itself, unless the patient's response to treatment tells me otherwise. You may ask, what about getting an MRI? So in general, an MRI isn't very useful in diagnosing Achilles pain. This is because about 59% of all people will have abnormal findings of their Achilles tendon on imaging, and that's people who are asymptomatic. So if we're relying on the imaging itself, we may be missing what's actually going on within the tendon. Not only that, waiting for an MRI is prolonging when they're able to start with their treatment. And MRIs are costly, so it's an added cost to the patient. So unless I'm suspecting something a bit more sinister, I tend to not want to get an MRI for these patients. Before pouring, I like to put a cocktail cherry right in the bottom of my glass. Achilles tendinopathy can be a really frustrating condition, and without a proper diagnosis, you are unlikely to get the most appropriate care. So, if your doctor is recommending injections, imaging, or surgery before physical therapy, or you're getting treatment that seems to not be helping, and no one has ever done a thorough investigation of your lumbar spine, you may need a second opinion. Cheers.